Okay, so I'm going to be presenting the cardiovascular lecture by voiceover PowerPoint. So y'all bear with me. This is definitely our scheduled lecture for today, and we're going to talk about fetal circulation first. It's important for you to know that blood flows from the placenta to the umbilical vein. Blood then enters the right atrium, and most of the blood enters the left atrium at that point through a special fetal opening. And we know that opening is called the foramen ovale. And blood then flows into the left ventricle. From the left ventricle, it goes, it's pumped into the aorta and then into the systemic, circulation. With the first breaths of life, of air, once a baby is born, the first breath they take at birth, that all changes. Blood that previously passed through the ductus arteriosus begins to flow to the lungs because of the decreased resistance. So, and then increased blood flows from this increased blood flow from the lungs then increases the left atrium pressure. And this increased pressure in the left atrium stimulates closure of the foramen ovale. Ductus arteriosus constricts. It usually closes within 10 to 15 hours after birth due to the high O2 sat. If the O2 sat remains low, this may not close in this timely manner. That closure may be delayed or prevented. So when you think about a low O2 sat, you might think of a premature baby or a baby with some kind of respiratory problems. Like I say, this transition can begins at birth, but it can take a few hours for it to complete. We know that the first breath expands the lungs and it pushes the fluid out of the lungs so that it can be replaced with oxygen, so there can be oxygen exchange, and it's actually air in the lungs. The pulmonary changes, of course, the blood begins to flow to the lungs. We just talked about that. And there's decreased pulmonary vascular resistance that allows that. And then you have increased left atrium pressure, and like I said earlier, that causes the foramen ovale to close. It continues in that we know that these systemic changes occur when the umbilical cord is cut. The baby is no longer dependent upon the mom to supply the blood flow. There's increased systemic vascular resistance and decreased right atrial pressure. The oxygenation changes occur, of course, and that those changes are what prompt the ductus arteriosus to close. So if there's adequate oxygen sat, you're going to have a closure of the ductus arteriosus. And this is just a picture of the normal heart. Really, it's got you have a good picture in your book, but that's just to show you how the heart looks normally, and we're going to be looking at some variations of an abnormal heart. So I just wanted you to look at that. I'm going to talk a little bit about cardiac cath initially, because it's in so many of these heart defects that we're going to see. Cardiac catheterization can be it can be used to correct the defect. But it is an invasive diagnostic procedure. It can also do other things as far as diagnosing the problem, locating the problem exactly where it is and everything, but it can also be used to fix the problem. A lot of data is obtained and there can be complications. We know that from just knowing about a cardiac cath. Of course, the same problems that can happen with an adult can definitely happen with children, and we'll talk about a few of those. And we'll also talk about the nursing care that is important with this procedure in small children. So we talked about the cardiac cath. So what other diagnostic studies might be used in this? Well, a chest x-ray is always good to know. It kind of tells us if the heart is positioned in the right location. It does give us some good idea of what we're getting into. But also, you might think about an EKG. Those are done frequently. They may, older child or even a smaller child could have a Holter monitor placed for usually 24 hours just to kind of get a little 24-hour history of what's going on with the heart. There may also be exercise testing, and that's just to see their tolerance. That would probably be with the older child. Maybe an echo, an MRI, and also a CT. Some of those are just, these are just some of the other studies that might go along with, that might be ordered for a child or an infant born with a heart defect. There is a table in your book, I think it's on 809, table 24-6, and that table just lists some of these studies that are done. It also lists lab tests that might be done for these children also. And in Appendix E in your book, it does give diagnostic tests that are often ordered for children, and it does help you see what the nurse's role is in teaching and preparing and all. So that might be something you might want to look at if you're not familiar with some of these. There it is. Okay. We're going to talk about congenital heart disease, and what that is a defect in the heart structure or the valves of the heart or any other major blood vessels that are present at birth, and these are all to do with the heart. The most common major birth defect in infants and children is congenital heart disease. And also we're going to talk about intervention. We do know that the heart develops during the 4th and 7th week of gestation. During that time, a pregnant lady and the fetus very susceptible to poisonous things like teratogens, and usually it's unknown, so they don't usually know that they're being exposed to that. But it can be a combined effect of genetics and environment also. Some examples of some of these dangerous elements would be something like drugs, alcohol, tobacco smoke, and any maternal infection. Some, of course, are worse than others as far as any effect they might have on the fetus, but infections in mom. Maternal age can cause some of these problems. Maybe some kind of problem during labor and delivery, or maybe just in pregnancy. Throughout pregnancy, mom just had varying problems. And of course, a premature baby. Congenital heart disease can occur by itself or with other problems. So anytime, we've talked about this before, anytime a baby has a problem, you definitely want to consider checking other things, such as things that might be developing during the same time that the heart developed. So we know the heart develops during the 4th and 7th week, so anything else that develops during that time, we would want to make sure that we check that out too, to see if there was a problem with that aspect. Some of these children may have a murmur. They don't always have to have a murmur to have these heart defects. They may be asymptomatic at first. They might not display anything that would alert you to the fact that there's a problem with the heart. But some do. Some do have signs and symptoms. And often, once they have been identified, they require either some kind of surgery or heart cath to correct. On page 809, there is also a table, 26.5, that talks about some of the congenital heart defects that are commonly associated with genetic disorders. So, we talked about how sometimes it can be due to some kind of problem that has been identified in the family or something. So that's just some of the things that are listed in that table. A lot of times what caused it is unknown, but it can be associated with Down syndrome and fetal alcohol syndrome, and we talked about some of the other problems. Let's see. As far as signs and symptoms, these children are going to tire easily, so you'd want to provide a relaxed environment. You would definitely want to time feedings before other activities because of the energy they need to feed, and you don't want them to be tired and then try to feed them and they don't have that energy. Small frequent feedings, you would want to hold them upright to improve any kind of breathing effort that they may need during the feeding. Some babies maybe don't have enough energy to suck a bottle, so they may need to have nasogastric feedings. And during this feeding, you want to monitor them for any kind of feeding intolerance, monitor their color, their respiratory rate, and that kind of thing. And you also, for these children, you'd want to observe their level of activity. Do they frequently stop what they're doing and rest? These are, of course, for older children. Are they irritable? Are they restless? Or do they sometimes just stop what they're doing and squat, like I say, to rest? It's very important to know early in the assessment, and it's very important for nurses to know what is normal, so that they can detect something that may be a little abnormal, such as blood flow that doesn't sound right. It's a noisy blood flow or something. So it's very important to listen and be able to describe according to the location, the intensity, and the duration. You want to listen for any of the clicks that might be a valve problem. And we already talked about some of the tests that you would do, but over time, the infant or the child may fail to gain weight, and they may eventually have failure to thrive. So, like I said, a lot of times they may not present with any obvious signs and symptoms, but if it is something that is there over time, it will make itself known in other ways, such as failure to gain weight. Interventions. You're going to observe these babies. You're going to watch these children in their activities. You're going to just kind of see how they tolerate different things. So you want to monitor them, listen closely, watch closely, and of course, as far as meds go, I was telling you about There are meds that are given. You definitely want to give the medications as ordered and on time. As far as the catheterization, we know that we've talked about that. And sometimes, like I said, it can be used to correct the problem. They may be able to open narrow passages. They may be able to dilate a valve or maybe close some kind of opening, some kind of abnormal opening. And also, a heart cath can measure pressures and O2 sat in different chambers of the heart and some of the bigger vessels. It can evaluate cardiac output. So we talked about valves and stents. As far as the complications, you can have a hemorrhage, you can have infection, they may have a reaction to dye, perforation. So you definitely want to be aware of things that can go wrong and of course watch for those. As far as nursing care, as with adults, they need to leave their legs straight for 4 to 6 hours. Many times it's more appropriate to have the parents hold the infant and just be aware of the fact that they need to hold that leg still. Some of them are going to be more still when they're in their parents' lap. If they are in the bed or even in the parents' lap, it's important that their head is that they're not lying flat. The head needs to be elevated 20 degrees. IV fluids until taking and retaining adequate PO fluids. Continuous monitoring. You want to observe the dressing frequently and check under the patient for blood. And of course, if bleeding is detected, you're going to want to address that immediately. Sometimes holding the heel of the hand firmly on the dressing and applying pressure will help, and of course you want to get help and call the doctor, of course, and let them know that. You want to monitor every 15 minutes initially, and then for 1 hour as ordered. Usually the doctor will give you instructions on how he wants you to monitor the patient as far as vital signs. One of the other things you want to do is make sure that you assess perfusion to the extremity that's involved. And like I said, if there's bleeding, you want to notify the doctor and have a little bit of an assessment of the amount of blood loss. Check the color, make sure that, check to see if they're mottled or whatever, and also the temperature of the extremity. You want to be able to palpate the pulses. And of course, notify the doctor if there's a change. So by doing it frequently, you should be able to notice if something is different. Some may have IV fluids going. Many times they may be discharged on the same day if it's a diagnostic cath. In other words, they're just looking to see what's wrong. Sometimes if they do some kind of intervention, they may stay overnight. Dressing is usually removed the next day and replaced with a Band-Aid. You would definitely want to give the parents good discharge instructions. So teach them to inspect the site, to assess healing or infection, any redness or drainage or anything they would definitely need to report. Limit bathing to shower or sponge bath for 1 to 3 days. You definitely would not want this child soaking in a bathtub. Avoid strenuous activity for up to 1 week. They can return to school if it's a school-age child. They can return to school 3 days after the procedure if everything is going well. You need to also tell the parents to call the doctor if there is a temperature greater than 101 or any kind of change to the site or any changes that they feel like should be reported, such as maybe numbness or something like that. You would want them to resume normal feeding patterns and of course their meds. If they have prophylactic antibiotics that they take before any medical procedure, you would want to make sure that they check with their doctor and continue that. On page 811, there is a table, 26.6, that talks about interventions for the cardiac cath for the congenital heart defects. It not only talks about caths, but it also talks about any kind of surgery they may be performing or whatever. So that's a good table to look at. Usually with these children, it's a lifelong assessment, and medical care might be required throughout their lifetime. Congenital heart defects, there's really three different kinds we're going to talk about. So this first session we're going to talk about increased pulmonary blood flow. Later we'll talk about obstructive defects, and then we'll talk about decreased pulmonary blood flow and mixed defects. So right now we're going to talk about increased pulmonary blood flow. It is usually a left to right shunt. It results from a defect that allows blood to flow between the left and right side of the heart. I'm sorry, just a second. It is the most common defect. In an increased amount of blood, it ends up going to the lungs. And that's because usually the blood is diverted from the left side to the right side, and because the left side has the most pressure. And so the size of the defect determines how much blood is actually shunted to the right side of the heart. Now we know that when it's shunted to the right side of the heart, to the right ventricle, it's going to go, or just to the right side of the heart, it's going to cause more blood to flow to the lungs. So it's extra burden on the lungs and the heart, and it could lead to pulmonary hypertension. These babies are going to be acyanotic. They're going to have good color. They're not going to be blue. Because for one thing, the blood is getting oxygenated over and over again, essentially is what it is, because it is oxygenated when it goes to the left ventricle, and then even oxygenated blood is coming back to the right ventricle, and that's going to the lungs for reoxygenation. There is increased heart rate, respiratory rate, diaphoresis. Sometimes these children have problems with gaining weight. It's hard to get enough calories in. They may have respiratory tract infections because of the amount of, or the volume of blood that's going to the lungs. It can lead to congestion, and it's kind of like a wet environment, so you might hear some different sounds with all the blood flow that's going through the lungs and the amount of blood that's going through the lungs. And this wet environment sometimes can support infection, so you would definitely want to be aware of that. So these are the defects we're going to look at real quickly: ASD, VSD, and PDA. And the signs and symptoms of that are going to be, we just talked about some of those, and so you see them here on the slide. As far as the atrial septal defect, that is an opening between the atria. And it accounts for 10% of all congenital heart defects, and many of them are asymptomatic. Over years, they may become more symptomatic by experiencing fatigue, or especially, I mean, they don't have, they may feel like they don't have as much energy as they had before, The symptoms, like I said, they're asymptomatic, and then they may progress as they get older. And these are some of the things you may see: palpitations, possibly congestive heart failure, murmur, and atrial dysfunction. You want to watch these children closely, though, and all that. Spontaneous closure can occur in these children. In other words, that little opening can close over time, and take care of any problems. However, if it hasn't closed by age 2, then they usually do some kind of surgery or catheterization to close it, and they may use a Dacron patch. They may use a septal occluder. And if it's not corrected by middle age, they may, like I say, exhibit some of these signs and symptoms. And it can lead to increased risk for stroke. And this is the atrial septal defect, a picture of it, and you see at the top of the heart, at the right atria, there is opening between the atria, and you can see how, because of the left-sided heart pressure, the blood is shunted back over to the right atria, and so that blood, that's going to mix a little oxygen-rich blood with the blood that's going to go to the lungs. So you can see why it wouldn't be cause these children to be blue. So let's picture the heart. The next thing we're going to talk about is the VSD, ventricular septal defect, and as the name says, that talks about that refers to opening between the ventricles. The symptoms are sometimes not seen at birth. Remember, these are not the babies that are going to turn blue, so they're not going to notice anything at birth unless it's a significant opening. But usually within the first weeks of life, they might notice something, such as maybe a little murmur, congestive heart failure, and then later on you would see failure to thrive. It is the most common defect, approximately 25% of all the congenital heart defects, and it often accompanies other defects. So, like if you have a ventricular septal defect, you might want to make sure that you check to see that there's not other associated defects. And the degree of the shunting depends on the size of the defect. So it might be small, it may be rather large. So like I said, that really does also is significant in that you would see this more if it was a larger defect. This and I did refer to this already, but the symptoms do vary with the size. The clinical symptoms are essentially kind of the same as the ASD. If the aortic valve is involved, surgery is indicated, and it may be sometimes. Medications are used: digoxin, ACE inhibitors. You're checking the nutritional status of these children. They may require an NG tube for tube feedings, or I get gastrostomy tube feedings, because they're not able to take in enough and support their need for growth. Children do respond well to once it has been identified and the defect has been addressed. children do usually respond quickly to that, and they actually catch up in any growth that may have been delayed due to their intake. Symptoms are usually, though, decreased fluid intake, poor growth, and infection sometimes. So, like I said, they may have spontaneous closure, and they may be on some kind of medication to treat the symptoms, and they may, at some point, it may advance to the need to repair the closure, to close it off with either a Dacron patch or a cardiac cath procedure. And as you can see, this picture shows the ventricular septal defect. This is a rather large one, but you can see where it was saying that if it's large enough to include the pulmonary artery, it would definitely need some kind of intervention early on. The next one we're going to look at is patent ductus arteriosus. And we know that normally the PDA is supposed to close. However, there's failure for it to close, and so the aorta and the pulmonary artery are still connected as it was in fetal circulation. The symptoms are going to be CHF. You will hear a machine-like murmur. There's going to be bounding pulses, irritability, and tachypnea. The treatment, prostaglandin inhibitors. So you would give prostaglandin to hopefully encourage that opening to close. They may do. It could be surgery in which they would divide it or put a clip on it to cause it the flow to stop going between the two main vessels. Cardiac catheterization might be used, and also and this other is just a website for you to see some of the PDA information. This patent ductus arteriosus does account for 5 to 10% of all congenital heart disease. You will see it more in preterm infants. They are more at risk due to O2 sat. Due to the O2 sat in some preterm babies. Manifestations, they can be asymptomatic. They may have a classic murmur, which we talked about. They could have an enlarged heart, poor feeding, and of course the management also includes Lasix or something like that, digoxin. They may have to have formula with increased calories so that they will get more calories with a small amount. You're going to want to provide rest periods to conserve energy. And of course the Indocin is the prostaglandin inhibitor, and it can be given to promote constriction and closure. And that is usually what it's used for. You'd want to monitor their renal functioning. Surgical intervention may include left thoracotomy, where the ductus is ligated. That's it there. And we did talk about how premature babies are more apt to have this due to them being less responsive maybe to the increased oxygen content, because we talked about how what causes that to close off is the oxygen content, the rise of the oxygen content in the blood. And this is a picture of it. Now you can see that little opening between the aorta and the pulmonary artery. That normally would close off, and sometimes it needs a little help. Another thing that we talked about, we didn't talk about, I'm sorry, but it is in your book when you're looking at the ones that we just talked about. There's another defect called the AV canal, and that's just defects in the septa and the valves. It is usually associated with Down syndrome. It accounts for 4% of congestive heart disease, or congenital heart disease, I'm sorry. And of those 4%, 70% have trisomy 21 or Down syndromes. So you normally do see that along with the AV canal. So this is the first section. There will be another section coming up. So this completes the first one. Thank you.